great. I read it every day. But I think it's important to point out the difference between following a book and the clinical practice of medicine. And I think that you have to make sure that you understand the differences.
Gentleman at the back.
No, I think that's an absolute fallacy, and the reason is that when I was doing a fellowship, I was asked to investigate chronic venous disease by Dr. Cranley. So I had needles in veins in the feet, and I had pneumatic compression pumps on the calf inflating very rapidly at 100 millimeters mercury. And then I had the patient do a dorsiflexion, and the pressure changes with the dorsiflexion, plantar flexion are about 5 times magnitude the compression of a 100 millimeter cuff on the calf. So if we want our patients to move their legs in bed, that is far more excessive than anything we could generate externally.
Any other questions from the floor? Gentleman at the back.
The question is temporary filters with catheter-directed thrombolysis. I happen to agree with Dr. O'Sullivan that it's unnecessary in the majority of patients. I also agree that if we see free-floating thrombus in the vena cava, we will put one in. But I would also agree that if we have an interventionalist that feels particularly uncomfortable and they want to put it in, I don't object, because you need to have people that are comfortable and happy who are doing the procedures. And then
a comfortable or happy interventionalist is kind of a contradiction in terms, but even allowing for that, I agree. I think you don't need filters in the majority of patients. It really adds to the cost. The only 2 patients that have done badly for me both had extensive IVC thrombus, and when I say did badly, sorry, they died of pulmonary emboli. At least I think they died of pulmonary emboli that night or the next day. One had thrombus up to an IVC filter. I put in catheter-directed thrombolysis on both sides. I left the catheters well below the filter and started thrombolizing. He died of a pulmonary embolus that night. I learned subsequently, and I put a second filter above it, and thrombus did break off and did catch in the upper filter, and I've proven that venographically. So if you have IVC thrombus, regardless of whether there's a filter present and you're going to treat them, I would put in a filter, even if it's above it. And if they've had a pulmonary embolus, you know then that they've got the propensity to develop a pulmonary embolus, so those patients also require a filter. But that's a small section of the number of patients, you know. It is very low, yeah.
Well, you're talking about symptomatic
True.
PE.
Yeah, not all patients got a CTPA.
At least 50%, probably more, of the patients with iliofemoral DVT, if you do a CT scan of the chest, you're going to find a PE in at least 50%.
Right. I'm going to start to wrap this up. Does anybody have a burning issue that they want to ask the panel about, other than the management of thrombosis, be it foam sclerotherapy or endothermal ablation? I know you're going to have listened to this afternoon. Does anybody have any burning issues that they want to ask? Because we're about 4 or 5 minutes before the next session starts. So if you're all happy and there are no questions, what I'd like to do is very much thank the panel for their participation. Thank you all for participating. And we start again in 5 minutes in the main hall. Thank you very much.